The Centers for Medicare and Medicaid Services set a very clear target back in 2021. By 2030, they want 100% of traditional Medicare beneficiaries, like the person holding this card, transitioned into accountable care relationships. The original idea behind this transition to value-based care made perfect sense. Instead of getting paid for the sheer volume of patients you see, your practice gets rewarded for keeping those patients healthy. But the execution on the ground looks very different. To prove those healthy outcomes to payers, practices now track quality metrics, close care gaps, and run constant outreach campaigns. That has dropped a massive, continuous administrative workload directly onto the shoulders of existing medical staff. And the pressure is only increasing. This chart plots the recent growth of alternative payment models, showing a jump from 24.5% up to 28.5% of all U.S. healthcare payments in just 2 years. More importantly, those specific contracts include downside financial risk, meaning practices actually lose money if they fail to hit their metrics. Clinical teams are now spending their hours wrestling with payer portals and endless spreadsheets. By forcing nurses and doctors to manage all these data points, we have inadvertently turned healing environments into highly stressed data entry factories. Practices are getting squeezed from the bottom up by skyrocketing labor costs. This bar chart builds out the true, loaded cost of hiring a single in-house care coordinator. By the time you stack up a base salary, benefits, payroll taxes, training, and the inevitable cost of turnover driven by hospital competition, a mid-sized practice is paying over $60,000 for one position. At the exact same time, that expensive structure is being squeezed from the top down. Payers require continuous, flawless reporting on performance metrics. There is no finish line, just a constant demand for data. The strain is creating what quality managers call paper gaps. A paper gap happens when a patient actually received the right care, but the documentation wasn't properly filed or submitted. Right now, administrative documentation failures, not actual clinical failures, account for 20 to 40% of all missed HEDIS care metrics. Mid-sized practices are losing out on their incentive revenue, and their staff are burning out. It is not because they are providing bad medical care. They are simply failing at a hyper-expensive, unwinnable administrative game. To fix this, high-performing practices are making a specific operational shift. They are entirely decoupling patient-facing clinical work from back-end administrative follow-up. Having your highly trained nurses and medical assistants make dozens of cold calls for missed mammograms is a poor use of their expertise. It degrades the quality of the care they can provide in the room, and it drives the exact kind of burnout that leads to rapid staff turnover. Scaling a practice in a value-based environment requires a highly specialized labor model. You cannot simply ask your existing clinical team to type faster and work harder. So what does that specialized model look like? A growing number of practices are outsourcing their value-based care administration entirely to dedicated EHR-trained virtual medical assistants through a company called Staffingly. This is distinctly different from hiring a generic offshore call center. These are specialized healthcare teams that operate strictly under HIPAA, SOC 2 Type 2, and HITRUST certifications, ensuring your patient data remains entirely secure. Here is how their process works. By scanning medical documents with AI tools like natural language processing, the system automatically extracts key patient metrics and sorts them. It uses duplicate detection to catch errors before they reach payer reports, amplifying the human team's speed. This tech-enabled workforce acts as an immediate release valve for the practice. It absorbs the crushing pressure of administrative tracking securely, accurately, and without adding a single desk to your back office. The integration phase is straightforward. The virtual team connects directly and securely into the exact electronic health record system your practice already uses, whether that is Epic, Cerner, or any of 100 other platforms. Accountability is built into the deployment. This org chart illustrates how the Staffingly structure supports your practice. Every account gets a 3-tier reporting structure: a team leader, a process manager, and a customer success manager. During the initial pilot phase mapped out here, these virtual assistants learn to operate seamlessly within your business hours. They follow local protocols, and once proven, that workflow transforms into a continuous loop of support. Because deployment takes only 48 to 72 hours, a process that used to be a grueling month-long hiring headache becomes a simple weekend implementation. The financial contrast between the two models is stark. A local full-time employee carrying those loaded overhead costs runs about $60,800 a year. Staffingly delivers the exact same full-time coverage for $21,600. As this comparative bar chart clearly shows, that is a massive mathematical advantage. By switching models, a practice generates nearly $40,000 in annual savings per position, which equals a 64% reduction in overhead. Clinically, this low-cost, dedicated focus allows your practice to systematically hunt down and close those HEDIS paper gaps. By simply fixing the documentation follow-through, your payer performance scores improve instantly. Practice owners are effectively flipping the economics of value-based care in their favor. They are reclaiming lost incentive revenue while permanently gutting the administrative overhead that was eating their margins. If you are hesitant about disrupting your current workflow, Staffingly removes the friction by offering a 2-week risk-free pilot along with a 30-day satisfaction guarantee. You can test this entire operational shift in real time. Verify the quality of the data entry, track the closed care gaps, and if the work does not meet your benchmarks during the pilot period, you pay absolutely nothing. Thriving under value-based care metrics does not require breaking your budget or burning out your best people. Book a demo today to see how quickly you can relieve the pressure on your practice.